Good morning. I just wanted to check my audio.
Good morning,
Thank
Rob.
you.
Me too.
Sound good.
Thank you.
Morning, Susan. Can you hear me okay?
Good morning. You sound great, Mr. Foster. It's good to see you.
Nice to see you, Miss Holland. How are you?
I'm doing well. Thanks for asking. And again, our eyes are always on Vermont, and we're really all out here thinking about y'all, and hope y'all are well as well.
That's really thoughtful of you. I forgot where you are. Where are you located again?
I'm in South Carolina,
South Carolina. What part?
right outside of Myrtle Beach.
Ah, lovely. Nice.
Yes, it's not too bad. A little rural for my children, but I quite like it.
Well, it's a little rainy here for my children.
Yes, I can understand that.
We'll just give it a minute here before we start.
Thank you.
Okay. Well, it looks like we have all the board members. Is Director Lindbergh here?
Present and accounted for.
All right, great. Well, good morning. I'll call to order the Green Mountain Care Board's meeting of August 9th, 2023. We have a couple agenda items today. We'll have some opening statements relating to the hospital budget season that is kicking off in earnest today. Then Director Lindbergh and her team will give an overview of the budget process, and we'll have two hospital budget presentations, Southwestern Vermont and Brattleboro. And then we have a potential vote relating to a modification of an order relating to OneCare. And so with that, I'll just open it up and we can get going. And I think first we're scheduled to hear from the Vermont Association of Hospitals and Health Systems, which I presume will be Mr. Del Trecco.
Yes, thank you. Thanks, everybody. Good morning, Chair Foster, board members, members of the public. I'll be brief as I know that you have a very tight agenda. First, I want to thank you and the board members, Sarah Lindbergh, her team, Mike Fisher, his team for dedicating time and effort to this process. You know, it's really unfortunate, but I know many of our offices have been damaged by flooding, and this has only added to the already difficult job. So for those dealing with that, I am in partner with you for sure. We're at a pivotal moment in
I'm so
healthcare in
sorry
Vermont.
to interrupt, Mr. Del Trecco. I've got a little bit of a technical issue. Could you bear with me for just one moment? I apologize, Chairman Foster. It's just one moment.
Sure.
No, take your time. And just a reminder for everyone, for Ms. Holland, who's doing the court reporting, speaking slowly. I know no one will speak over each other, but going slowly is helpful for transcribing.
Testing 1, 2, 3. Testing 1, 2, 3, 4. Testing
Sorry to interject here. I believe we won't require the court reporter until the hearings start. We won't necessarily need that at this point. Is that correct? But for those who are more familiar with operations.
I wouldn't mind a transcript. If Ms. Holland's here, we might as well.
Sure, why not? Okay.
If that's okay, yeah.
Yeah, that's fine. Thank you. All right.
Stand by. I'm just rebooting my system. One moment.
Take your time. Welcome.
Testing 1, 2, 3. Testing 1, 2, 3, 4. Chairman Foster, could you count to 3 for me if it's no trouble?
1, 2, 3.
Let me thank the group for that consideration. I do apologize. Sometimes these things have a mind of their own. I'm ready to proceed. I appreciate, again, there may be, Mr. Del Treco, if you didn't mind just maybe going back a bit or just starting over, that would just ensure a clean record. Thank you all. Thank you so much.
No,
Yeah, thank
no
you.
problem. Again, I wanted to say good morning to Chair Foster, board members, and members of the public. I'll be brief as I know there's a very tight agenda ahead. I want to thank you, the board members, Sarah Lindbergh and her team, Mike Fisher and his team for dedicating time and effort in this process. I know many of our offices have been damaged by the flooding, and this has only added to the difficult job. We are at a pivotal moment in healthcare in Vermont. You know all the issues, there's a very bad echo right now. I'm profoundly concerned about the welfare of our hospitals and the communities they serve. This work is never easy. Balancing the demands of community access, health equity, quality, operational efficiency, while managing increased utilization, aging demographics, unprecedented healthcare inflationary pressures, mental health and long-term care systems that are broken, attacks on our staff that further stress our already challenged workforce is, to say the least, very difficult and exhausting. When you add these specifics to the challenges brought on by operating in the most rural state in the nation, where we face numerous transportation shortfalls, limited opportunity for economic growth, and massive socioeconomic issues, frankly, the work sometimes seems impossible. Without the talented and dedicated hospital leaders, primary care and specialty physicians, nurses, registration staff, radiologists, lab techs, pharmacists, facility teams, I know we'd be having a very different conversation today. I applaud these individuals and thank them for their dedication and the life-altering work they do every day. Very importantly, these budgets that will come before you represent only what is needed to support and care for communities that Vermont hospitals serve. Over the next couple of weeks, you'll hear about this, the many operational efficiencies in place, and how Vermont hospitals are managing the challenges I've outlined. The margins or funding of these budgets, again, represent only what is required to invest in our caregivers and organizational needs. And it's foundationally important to remember our hospitals are not starting from a place of stability. In 2022, 9 of our 12 hospitals operated at a loss, and those challenges have trickled into 2023. It's not realistic to think we continue to deplete cash to fund our operations. We need balanced funding to support the highly skilled and talented workforce that is necessary to care for our patients and to keep their organizations safe for families and friends. Again, I'll close by saying thank you. I know we're about to embark on a long process through this budget cycle. I appreciate everybody's time. And I'll just close again by saying these budgets are about supporting our organizations so they're here for Vermonters today and well into the future. And I appreciate your time and the opportunity to speak with you this morning. Thank you.
Thank you, Mr. Del Treco. We'll turn to Mike Fisher, the healthcare advocate, and then we'll go to board members for any questions or comments they may have, and then we'll turn to Ms. Lindbergh. So Mr. Fisher.
Good morning, Mr. Chair, members of the board. I think I can echo pretty much, well, almost everything Mike Del Treco said. I agree. This is an exceedingly difficult task, and that we all know that we need strong hospitals in our communities. Every year, Hospital Association and the Healthcare Advocates Office kicks off this this proceeding with pretty similar comments, recognizing the challenges in front of hospitals, the challenges to make sure we continue to have good care available to us in the community, and the challenges Vermonters are facing being able to afford that care. And so in line with that, I'll just repeat the same concept that you've heard me say before. A great, high quality, local community hospital means little to me if I don't think I can afford to go. And I think that is, so even though I fully recognize that the statute is not as clear for you about the balance between affordability and solvency in the hospital budget process as it is in the rate review process, I think we live with the exact same dynamic, balancing those two competing interests. In the past, over the years, the board has given much of what the hospitals have asked for to them. And so let me switch a little bit. Sorry. I want to recognize that the Healthcare Advocates Office puts a decent amount of energy into soliciting, encouraging Vermonters to comment in the rate review process. We don't put that same effort into the hospital budget process for a couple of reasons. One of them being that we've just been out there doing it a month ago, and it seems hard to go back to people. And one of them is sort of the recognition of 14 hospitals in 14 different communities is more difficult to go out and say, hey, come comment. But I think everyone here knows that the comments that the board received during the hospital budget process, I'm sorry, that the board received during the rate review process apply to this process just as much. Nobody here would, everyone here, I think, recognizes that a significant factor, maybe the most significant factor in the rate review process is provider billing, is the cost that providers, the rates that providers charge. So I want to link them and encourage you to think about all of the comments that came to you during the rate review process as applying here just as much. I think we have an opportunity today, this year, to turn the page on how we review hospital budgets. We are really encouraged by the work of Sarah Lindberg and the hospital budget team, taking a deep look at Vermont's revenue and costs and compare them to national and regional benchmarks. But data is not good in and of itself. We're hoping that that the collection of this data helps the board make recognize the real cost to Vermonters. We encourage the board not to take a one-size-fits-all approach to hospital budgets and carefully examine what each hospital has presented and submitted. Some hospitals have taken difficult and courageous steps on their own to cut costs and improve patient financial assistance policies, but some have not. We believe that many hospitals will not make these decisions to cut costs unless the board takes action. What we hope for and what I think Vermonters need is an evidence-based regulation that not only looks at hospitals, at revenues, but also at costs. The evidence that Vermont hospitals need to be required to substantially cut costs is clear to us. With that, I think I will close and say thank you again to the board and to all of the hospitals. I know this is a difficult task in front of you, and we look forward to participating.
Thank you. Can somebody just give me a hands up if they can hear me? My audio switched. Okay, great, thanks. Are there any board members, questions or comments for Mr. Fisher or Mr. Del Trecco? I had a couple quick ones, if that's okay. First, and maybe this will be actually in the substantive budget review itself, but there's a couple things I struggle with as a regulator, or a new regulator, I should say. And one is, if a hospital is not controlling costs well, but needs the money, should the board provide it the money? So for example, huge disparity in traveler costs between some hospitals in Vermont. Some hospitals did better with that, some didn't do as well. And some of it, not all of it, but some of it could be attributed to decisions that were made. So should the board give all situations if it's found that the hospitals didn't do as well as potentially they could have? You know what I mean? So it's a bit of a catch-22. Either we say no, in which case you don't get the money that is needed for the care, but it sort of bails out or subsidizes a decision that had a negative consequence for Vermonters. And I was curious on both of your views on that kind of situation.
We might be both waiting for each other to go first. I think that hospitals are always going to know better the details of their budget. And I think that there's some risk if the board attempts to micromanage specific areas of spending that would be very difficult for the board to actually do. On the other hand, the board's role, in our view, is to put real pressure on hospitals to say, I'm sorry, the pressures on the community, the pressures on costs are too much. You're the experts in knowing how to do it. Come back to us with a corrective, with a plan on how to actually accomplish the holding the line on increased spending. I don't know if that helps, but I think that's the frame that I would approach it.
So thanks, Mike. I was having a hard time clicking off my mute. So I think there's varying reasons why organizations are successful in doing certain things, and you use the traveler example. Some organizations have different staff makeup, their services are different, and they require different specialties and skills. The thing to note here is that we're in a national marketplace for labor now. There are many challenges, so the opportunities may look different at each organization. So I think it's a hospital by hospital discussion. In the affordability efficiency space, I think the one thing to note in your question, Chair Foster, is the simple reality of people will go and get their care, whether it's in Vermont or out of Vermont. And we would have to evaluate and recognize that people go out of the state, that expense still exists. So to keep funding within the state, to keep resources within the state would be that would be a priority of mine. It may not be of the board's, but I think to keep those services and funding in the state is something that would be desirable. Keeping care local is very important. As I mentioned in my opening remarks, we are the most rural state in the nation. Transportation is a huge problem, whether it's public transportation or, frankly, individuals not having the ability to have a reliable car or other means of transportation is clearly a challenge. So these are things that I would be thinking about as I evaluate decisions. I too think that there's some opportunity to create and move forward some understanding of measures. I do worry a little bit about measures that haven't been vetted to date and not lack of understanding about what the data looks like. But I do know, as I mentioned in my remarks, that we are at a pivotal moment. The decisions we make here today, the decisions you make, I don't make any decisions in this process. The decisions that you make will have significant effects on organizations. So thank you.
I think you're really right. I read your letter that you submitted last night, and I thank you for doing that, because I think it helps frame some of our thinking on this from that point of view. And one of the things that stuck out was that there's some discussion of admin costs and discussion of reform costs and regulatory costs. But I presume that those aren't the only, if it is found that the hospitals have excessive admin costs compared to peers, those wouldn't be the only reasons, I presume. And I guess the question is there any sort of calculation of how much of those costs are contributing to the admin costs?
So I happen to have had the fortunate or unfortunate ability to submit many cost reports in my life. And organizations across the country submit those costs differently. There's a whole host of activities that happen within that space. So, I don't want to get too geeky here, but the cost report, the first 20 some odd lines are overhead. They include things like medical records. They include things like depreciation and investments in information technology specific to electronic medical records. They include things like direct patient care for pharmacy and lab. It's a very interesting administrative number. When you look at the only line item, I think it's line 5 or 6. It's been a while. That is the administrative cost, the direct admin cost in those organizations. So it matters how the comparison points to those other organizations. It matters if those organizations have own and employ physicians. There are many details when we're looking at comparative points. So apples to apples, apples to oranges is important to think about. So again, I would say carefully look at those things and ask those questions, but it's not always what meets the eye.
And then on the reform costs that are referenced in the letter, I think of reform as a chance for hospitals and others to do better financially, not to do worse. But it seemed to be cited as something that was a cost in the admin, which might explain higher admin costs. Was your reference to the reform costs indicating that net it costs hospitals more money than they save?
So when you're looking at administrative costs directly, there are certain things that that we have in the state of Vermont that other organizations around the country don't have. We have investments in OneCare. We have investments in your organization. We have investments in provider tax that are well above, we're at 6% of our net patient service revenues. Other states are well below those amounts. So I think that was the intent of that. That was the intent of that discussion, Chair Foster.
So what I was trying to get at, so I think of OneCare and the amount of risk they take, and then the amount of money they can make if they hit the total cost of care, and the money can go through the participating hospitals as a benefit, right? Like additional money, because the total cost of care is set fairly high. And if you're below, which I think OneCare generally is for Medicare, you're savings. So I didn't view reform as a cost, saw it sort of as an opportunity to do better financially. And when I read the letter, I thought it was indicating that it was a cost and not a net positive. And I don't know the answer to it. So I was curious if you view it as a net negative financially to the hospitals or a net positive.
The math probably looks different at each organization. I don't know the specifics of that math, but the administrative piece, if you're looking at administrative comparisons, the net of what we're talking about doesn't matter. We're looking at admin to admin. So when so that's how I would think about that. When you're looking at it in total, I'm sure it varies by organization if there's a benefit or a loss.
I see. So if it's an admin cost, it's an admin cost, and whether or not there's revenue from it, that might be somewhere else and not netted out in the admin cost.
Correct.
Got it. Last question, which is something I struggle with. We get a lot of comment and information from patients, businesses, Vermonters about the cost of healthcare, and they have been rising pretty significantly. I think it's 45 to 80% ish for the qualified health plans for the last 5 or 6 years, which is a lot. And we know the hospitals have financial need. We understand that. We recognize that. We recognize they need to be financially strong. The other set of letters we get and communications we get are from all the non-hospitals, the independent primary cares, the substance abuse, the mental health, the long-term care. And in my view, those are very critical to helping the system, patients, and hospital finances, right? Those are very important to help the hospital's financial burden, that there's good infrastructure of that around the hospitals. And some of the feedback we've been getting is that the hospitals are getting higher rates than all of those others. And so when we look at these hospital budgets, we can't look at them in a vacuum. We have to look at the whole system. And I was curious your thoughts on how we should balance the fact that hospitals have serious financial need right now, but then we're also hearing from patients, and Mr. Fisher's point, that people are getting priced out of insurance or buying down the kind of insurance they have or avoiding care altogether. And then also all these non-hospitals are providing information that they need increased rates, and that when we give it to hospitals, it's impacting their ability to be solvent themselves. And in your view, how should we think of that and balance that in this process?
Yeah, first I'd say, based on the household surveys, it looks like the burden on hospital debt is going down year over year. Not to say that affordability isn't a challenge, but we're moving in the right direction. Secondly, under the federal tax credit, no one should be paying more than 9% of their income towards those premiums that you've mentioned. And then there's additional subsidies if there are challenges. So clearly I and my members understand the challenge of affordability, and when these budgets are built, there's many analytical analysis that goes on about operational efficiency. It's no surprise that we all belong to organizations to drive down our supply costs. It should be of no surprise that the position control and FTE management happens daily, and that includes nursing shifts, that includes filling vacant positions, that includes evaluating and creating appropriate targets for FTEs in finance, FTEs and in those administrative areas. So there's many variables and components in this conversation. And I would say, again, our hospitals recognize deeply the affordability challenge. And I would go back to saying that if we drive patients out of Vermont through this process and decision making, we certainly will still bear the cost, and it may even be higher. That's uncertain, but the cost will still exist.
So I'll jump in. I read the household health insurance survey to say something a little bit different from my perspective. I think that the steady trend in increased underinsurance is indisputable. I don't know of anybody who thinks medical debt is less of a problem today than it was in recent years. We hear clearly from Vermonters that they choose not to follow medical advice because they have to make an economic decision, not a healthcare decision. And so all of the sort of the concerns from the hospitals of what happens if they can't provide the care already exists for Vermonters who are making the choice of who are dealing on the ground today with how do I get the care I need or my loved one needs and be able to afford the out-of-pocket costs or the costs. And then I'll also add, hospitals make a lot of strategic decisions. The board doesn't make strategic decisions. What investments to make, transfers to affiliates. There are major decisions that hospitals make that I think the board can evaluate. I think that's a place where we turn to as we look at many of the hospital budgets. I don't doubt I know that hospitals are thinking about access and therefore affordability, but they don't see it from the lens. Well, I don't think they see it from the lens that I see it from when I'm hearing from people who can't get in to get care.
So that's the crux of what I'm struggling with is, to me, there's almost three constituents, right? There's Vermonters who are saying they can't afford to get care, and they're telling me they can't afford to have insurance. And then that's one, can't afford care. Then there's the non-hospitals who are saying that they can't afford to provide the care. And then there's the hospitals saying they can't afford to provide the care. And so I know it's the crux of the job. And my question is, I guess, really both of you, is how do you see our role in, should we be considering those three sets? And how do you see that balance working here? Because I do not dispute or disagree that the hospitals are in financial difficulties, but then there's the other two sets. And that's what I'm trying to balance in my head as we start this process. So
Chair Foster, I would say, 98% of Vermonters have insurance. It might not be the best insurance, but 98% of Vermonters have insurance. We worked with Mike Fisher and the HCA team to pass a charity care bill last year. I believe it's Act 119. And these are all efforts in the policy space to address this affordability challenge. In addition, we will work with any patient anywhere at any time to make sure that they get the care they need. We have charity care people. We have people that help individuals get enrolled in Medicaid. We make sure that they're on the Medicaid rolls when they need to be. We help them enroll in the marketplace where appropriate. And if there is a shortfall in their care and coverage, our charity care policies are designed to make up that difference. Does it work perfectly every single time? Is it sufficient to the 100%? Probably not. But we are maximizing that opportunity every day because we understand and we care for the communities we serve. This notion that it's not great for me to hear that individuals are delaying or postponing care. That should never happen. Michael Fisher, if you have a list of those people, let's get them going, and let's stop saying there's a list and let's move it forward. Because to say there's a list and to say that there's these challenges without addressing them at the local hospitals is a problem, and we can solve that literally today. That's how I would respond to that. And I know the challenge that you have in balancing these hospital budgets, affordability, and efficiency within these organizations is a deep and challenging job. I sit here today saying that I spent a lot of time with our hospitals in this budget process. Their hospital boards reviewed these budgets, and they are community members. They understand the pressures of each community and the affordability challenges. So I can sit here with a great degree of certainty and say, this is needs-based stuff. Beyond that, if there are individuals that need our help today, let's get that going. I'd rather do that than this job right here today that we're talking about.
And
what about go ahead, Mike.
One final thing, maybe for me at the moment, is I think we hear in the public comments the expression of people who feel like they have to make an economic decision instead of a healthcare decision. But I think I also want to steer back to the chair's original question. I guess I want to say thank you for bringing another seat to the table of the healthcare providers that are not immediately in front of you here, or actually not in front of you at all, because you don't regulate them. And to ask the question, what is the relationship between your decisions on commercial rates at the hospitals? What impact does that have on the availability of a reasonable rate for those non-regulated providers? In other words, does your regulation of hospitals assure that they will get the money that they need, and therefore make it harder for the rest of the healthcare industry. It's to get its appropriate funding. It's a great question, and one that I don't think we have there's no easy answer to. You don't regulate them, but I think it's a key dynamic that I think we see staring in front of us, and one that is important to bring to this table.
Yeah, I think when we reconsidered the VAWS request on the hospital budget guidance, there was a really huge volume of letters suggesting or indicating that they felt that if we gave the hospitals the requested rates, that they would get a fraction or 0 or 1 or 2%, and that was having a negative impact. And so I am curious how we should be thinking of that as we head into this process from VAWS and the hospital's perspective.
I would say there are no guarantees. We aren't guaranteed a rate increase through this budget hearing process. In your orders, you speak to caps and negotiations. So there are no guarantees. I think you've addressed that.
Okay, great. Well, I appreciate the dialogue and your perspectives on these issues, because I think they are, to me anyway, as one board member, they're sort of the real rub of all this and the real challenge that we have. And I appreciate you both being respectful that is not an easy thing to balance for us. So thank you for your thoughts and
thank you.
Understanding that difficulty we have.
Can I follow up on one question that you had asked, Chair Foster? The first question, the way I understood the question, I think Chair Foster was asking, and I'll switch to a hypothetical non-Vermont situation. So I think because Mr. Del Trecco is, I think, the representative of Vermont hospitals, it puts you in a bit of a challenge to answer the question without sort of considering an individual case. But if one was to hypothetically say, okay, we're presented data that a particular hospital is struggling with performance in an area, say managing expense growth, and they're asking for a substantial increase in a commercial rate increase. What are some suggestions you would have the board consider, as opposed to, we can discuss the validity of the data, but say hypothetically, we've come to the conclusion that the data trend is valid enough to be concerned about expense management within this organization, but the rate that they're asking for is high. How should the board consider that from your view? Should the board continue to grant high rates with a hospital that's had continued expense growth management over time? Or should the board consider decreasing those rates to try to encourage the hospital to become a more sustainable organization over time? Or is there a third option that you would suggest to us to consider?
Sure. I'll leverage some of my experience in the financing area and going forward to ask for borrowing money. There's a set of financial metrics. Those metrics are fluid, and those rating agencies and those places where you're borrowing money from look at those metrics. And if you're underperforming in some and overperforming in others, there's a set of questions that go with that. Why? What is your performance correction? What's your corrective action plan on performance to improve some numbers? But remember that those numbers are not static. They all move for certain reasons at certain times. So I do think there's a third option. And I think that third option is having that conversation with that organization, outlining your concerns, speaking if there is a plan in place, understanding what that plan may look like, and then moving forward and monitoring that plan. This board has done that in the past with organizations. So I do think that's an option.
Okay, so and I think just from the standpoint of a board member who's new to this process, I think one of the challenges that I foresee is, and I think your suggestion here would be, okay, so you have an organization that has, potentially, hypothetically, non-Vermont organization. We're not a Vermont board, so we can sort of hypothetical this scenario to get you out of the bind that you're in a little bit. But an organization that has a series of underperforming expense management growths, and your suggestion would be to approve the budget but put in a corrective action plan of some kind or reporting plan to try to improve that expense management growth. But in the meantime, that then leads to a higher commercial rate, which leads to higher commercial insurance, which leads to affordability / underinsurance, having to choose a bronze plan instead of a silver plan, higher deductibles, as you say, and I can refer you patients when I see them in the emergency department to say, please call Mr. Del Trecco. He would like to help you with managing your challenges with deferring care because of your high copays or delaying till next year because you don't want to get, you're trying to put it all into 1 year or whatnot. But it's real. So if we approve that budget, we increase that commercial rate, that translates to commercial rate insurance increases. That translates to challenges for people for affordability. But what you're suggesting is that the corrective action plan within that would be sufficient, you feel, to work to that, say, expense growth issue.
That's a big hypothetical question. And I think that there are opportunities to have the conversation with those organizations, evaluate, and you need to make the decisions you need to make. I do think that these organizations, when you assess operational efficiency, cost growth, I think it is important to understand what those numbers are comprised of. When you look at some of our indicators on per beneficiary growth in Medicaid, in Medicare, we're very, very good. Our Commonwealth report, which measures several dimensions of healthcare, we're in the top 5 historically. So I think we also have to step back and say, and embrace and say, look at all the actually powerful things that we've done in Vermont, rather than this moment of we have this massive affordability problem, and look at that as the single deciding factor. If we hadn't done some of the things we've done historically since the inception of the Green Mountain Care Board, things probably would look a lot different. Our hospitals embrace healthcare reform, from southern Vermont to northern Vermont. Our small communities, our critical access hospitals that enter into these all-payer model agreements, it wouldn't happen in any other state. They would say, no, I'm not taking that risk. This is outrageous. But we don't. We actually step up. We are actually doing this work. So where are we versus where we could have been needs to be evaluated in that conversation.
I appreciate that response. I think you highlighted something that I think is something that we're going to be having to try to understand, which is data and metrics. You cite certain data for high performing, and there's also data that sort of discusses high cost. And I think that almost what you're saying is that no data is perfect data, and so we're going to have to deal with the data we have. So I appreciate that response.
Thank you.
Yeah, and on Dr. Merman's point, it seems like there's pretty big disparity even within Vermont hospitals of operating expense growth. Presuming this data is accurate, you see, Copley at 5% expense growth over 2 years. I think UVM Medical Center 15, Porter 17, and then Northwestern just down at 3.54. There is a large disparity in the expense growth, and that is something that I think we have to grapple with as we do this. And I have, I'll email you right now, actually. I met with a patient Monday night who was having financial challenges. He advised that he had a missed cancer diagnosis and was on a payment plan, but then went to collections. So I'll email you that person's name and contact information. I'll ask him if it's okay with him, but I appreciate that offer. I think it's great.
Chair Foster, but before we move on, you mentioned again expense growth and the administrative component to that and variation in administrative expenses. And earlier in the conversation, it was brought up that regulation is something that needs to be paid for, and that's a potential cause of some of the growth in administrative expenses. But I just want to point out that federal regulations apply to all hospitals. So when we compare one hospital to another, we can't claim that one place is suffering under federal regulation more than another. It's all the same. And all 50 states regulate healthcare. It's often said that Vermont's unique, but every state can rightly say that it is unique because they all design their own regulation. So they all have regulation expenses. And when we compare Vermont hospitals to other hospitals across the country, those are already factored in. I don't think it's correct to say that the regulation expenses in Vermont are outrageous compared to other places. Every place deals with those. I just wanted to point that out because of earlier conversation.
Just to correct one thing, I don't know that they're outrageous. They exist. So, and they may be different from state to state, but I do know what there are 629 over 629 federal regulatory processes that happen throughout the country. But there are unique things that happen within the state. So those are the issues that I've pointed out.
Mr. Chair, I think sorry, Member Walsh, were you still?
Yeah, I agree. There are a lot of federal regulations. They apply to every hospital, and each state has regulations that hospitals within that state have to deal with.
Go ahead, Mr. Fisher, and then I'm getting some messages.
Yeah,
that we should,
I think it's time to move on, but I did want to make a simple point, and that is that it's easy to see the individuals who come to my office or to Member Herman's emergency department as individuals who need to be addressed, and they do. I run a whole shop that addresses people's individual needs. This is a structural problem. This is not the failings of some individuals. This is a predictable outcome due to the system we have. I just want to make that point. Thank you, Mr. Chair.
Great. Well, thank you both very much. Oh, go ahead, Mr. Deltreco.
I just want to say thanks for the conversation. I think this is important. I think this dialogue demonstrates everyone here's commitment to what's happening. So I appreciate that. And, I know we have a lot of work ahead of us. So thank you.
Same.
Thank you, Mike Deltreco. I agree.
Great. Thank you for your time and for making opening statements today and for the dialogue. I think it's really helpful to the process. And I will excuse you both, and we will turn to Director Lindberg.
Good morning. Our slide's showing up for other folks. Great. So thank you very much to Mr. Deltreco and Mr. Fisher. They had been invited for brief opening remarks, and that was a very robust conversation. But from a process standpoint, we'll make sure to build that in for time in the future if we end up having a Q&A for our closing remarks. So Sarah Lindberg, Director of Health Systems Finance for the Green Mountain Care Board. And I am here to just present an overview of the hospital budgets that have been submitted for fiscal year 24. We will be walking through the budget process, and Russ McCracken will be walking through that with you all. And then we will cover some national context, some overview of the 24 submissions, and give you a preview of the budget review tool that will be guiding us through the submissions this year. So with that, I will turn it to Mr. McCracken.
Great. Thank you, Sarah. I just wanted to provide a little reminder of the budget process and some of the elements of the guidance and the statute that the board has, adopted in the spring, and kind of what the statute sets out for this budget review process. So on an annual basis, the board has the responsibility to review and establish budgets for Vermont's 14 community hospitals. In its review, the board is going to consider factors including labor expenses, utilization, pharmaceutical expenses, cost inflation, commercial price increases, financial indicators, known pricing changes for Medicare and Medicaid, uncompensated care, and other factors. Sorry to read the list. This is all these are the factors set out in the guidance that the board adopted back in March. As part of this, the board is also going to hear and consider testimony from the hospitals and receive and consider comments from members of the public and the healthcare advocate. So the second bullet here is a statement that came out of our guidance, but it's a reminder that the board executes its budget review and consistent with its statutory obligations. So the review process is, as required by statute, consistent with the principles for healthcare reform that the board is obligated to follow, that are set out in 18 VSA 9371. Section 9371 sets out 14 different principles as a framework for healthcare reform. Those include the principle that all Vermonters must receive affordable and appropriate healthcare at the appropriate time in the appropriate setting, and the principle that overall healthcare costs must be contained in growth in healthcare spending in Vermont must balance the healthcare needs of the population with the ability to pay for such care. It's important to note here that the board's review process also must adhere to the hospital budget requirements set out in the hospital budget statute of 18 VSA 9456, which, as a reminder, says that individual hospital budgets established under the section by the board must be consistent with the health resource allocation plan, must take into consideration national, regional, or in-state peer group norms according to indicators, ratios, and statistics established by the board, which again is covered in the board's guidance that was adopted earlier this year. Budgets must promote efficient and economic operation of the hospital, reflect budget performance for prior years, address the hospital submission for an analysis reflecting a reduction in net revenues for non-Medicaid payers, and demonstrate that they support equal access to appropriate mental health care needs that meet the standards of quality, access, and affordability equivalent to other components of the healthcare system. There are some procedural aspects to this as well, including that the board will meet with hospitals, which we're starting today. And then as a further note, as the board knows, decisions must be made by September 15th, and then written orders must be issued by October 1st. Those are dates set out in the statute as well. For any further questions from, and as a reference for the public, we have a link here at the bottom that gives access to all of the background guidance and hospital budget materials that have been submitted. So next slide, and I think I'm turning it back to you, Sarah.
Yeah, thank you. And just for the back of your mind, for the first time, according to a statutory change, we will be engaging in a full budget review of the Brattleboro retreat. However, their fiscal year is different than the community hospitals, so we'll be taking that up later this year. For the 14 hospitals before us now, we have a public comment period that's been in place for a bit. If you would like a comment to be considered officially and synthesized by staff, we would like to see those comments by noon on Friday, August 25th. However, as hopefully is well understood, we welcome comment at any point. Budget materials for each hospital may be found online, and you can see the most recent budget schedule online as well. We've had to make a few tweaks along the way. New board members didn't know they didn't get a summer apparently, so. All right, as far as national context, so we know that inflation has been increasing significantly in the past few years, historically high inflation. There is evidence that that is cooling to more historically typical levels. But as you can see, inflation as measured for medical services and all goods and services tend to be a bit lagged. So often the prices for healthcare are very sticky, meaning that they can only be updated once a year. And so sometimes if you shift this curve, you can kind of see a more direct correlation. But for now, it looks like both are decreasing significantly in the most recent information available. We also see that that we are starting to see some recovery nationally. So this is from a Kaufman Hall flash report with operating results through June. We can see that the year-to-date margins are starting to sugar out to be positive. However, we're also seeing growing disparities between hospitals who are recovering successfully and those who are still unable to get back to where they had been. I think there's some questions about what the new normal is going to look like and how we're going to interpret what recovery looks like in this new environment. So if you look at the national landscape, there are some very hard decisions that hospitals are having to make. I just pulled a few headlines in recent press. So Becker's currently sees 76 hospitals and health systems who are cutting jobs. The last headline is from the Valley News talking about Dartmouth Health's initiative to cut $120 million out of its budget. They're planning hiring freezes and making sure to review jobs. These are measures that I think Vermont hospitals are undertaking as well in a lot of cases. And then we see that the layoffs are hitting the healthcare sector, which is unusual. It tends to be a sector that is somewhat protected in these situations, but we see that there's an 81% increase in layoffs, according to the health exec study that is being cited there. So those are jobs that are being lost, and I think that that's as a regulator a hard thing to understand that might be necessary right now. When we look at employment trends, I think we've covered this before, but if you look at kind of the recovery in jobs since the pandemic, jobs are not recovering anywhere near where they had been expected to be. So that labor market is extremely tight, and that is being felt here in Vermont. But we also see on the right that the consolidation effect. So more and more physicians are being employed by hospitals or other corporate entities over time. And we see that escalating as people, again, try to grapple with some of these difficult financial challenges. Probably not news to anyone that pharmaceutical expenses are a significant expense pressure being faced not only by hospitals, but by consumers as well. You can see that especially new drugs going.
Sarah, this is Dave. I don't know if you're advancing your slides.
Oh,
I have it still
to.
on slide 8. I don't know if other people are still seeing that or if.
I'm on slide 10.
Okay. All right. That's my issue then.
It's possible you navigated away from me. Yeah, I don't know.
Yeah, I can go through manually. So, okay.
Okay. No worries. So we see that it's these new entrants that have quite high price tags. So these often are specialty drugs. There's some being marketed right now related to Alzheimer's that are significantly expensive. There's also some new emerging trends in drugs that are designed to help with obesity that are quite expensive. And you can see that these trends are just difficult to control. The supply chain is very complex and obfuscated. So this is one that I think federally we're trying to grapple with. Another national trend is we see more and more care moving to an outpatient setting. So inpatient meaning that's when you get checked into the hospital and stay overnight, whereas an outpatient procedure often you might think of as day surgery. So this is showing the trends as it relates to hip and knee replacement, changing settings. Historically, inpatient revenue is a lot easier to predict and budget for, whereas outpatient tends to be a lot more mercurial and a little bit more sensitive to some of the variable costs that providers face. So also tend to see higher relative reimbursement in the outpatient setting as compared to inpatient. And I think we've seen this slide before, but as we can see that, inflation since 2000 has been twice that of the overall inflation for hospitals and health services. Or I'm sorry, that's specifically hospital services that grew at 227% compared to general inflation that grew at 104%. Or I'm sorry, 74%, whereas the hourly wages increased by just over 100% from 2000 to, this is through June of 2022. So these inflationary expenses, as felt by consumers, have been compounding over time. And rural hospitals are particularly vulnerable. Their revenue is based on the cost of what they provide largely to Medicare beneficiaries, and that their margins are often very tight. If generally trying to just break even. So they've been very vulnerable in the volatility associated with the pandemic and all the associated aftermath. So we do see some hospitals at risk of closure here, according to our colleagues over at, their name is escaping me. Sugar, the Rural Health
Center?
Project.
Is it
Shep
the
Center.
Shep Center?
Thank you. Oh my gosh.
Okay.
Thank you so much. So they do really great work over there. I can't believe I forgot their name. So yeah, so that's just, a reality that, if hospitals close, that has an effect on communities, and just trying to understand that effect. All right, so the submissions that we got. So I would say in my reading and in consultation with the team that we see that, the hospitals that Vermont hospitals face do mirror most of those that we're seeing nationally. So we see that continued reliance on non-operating revenue, which can be especially vulnerable. Some of that non-operating revenue was provider relief and CARES Act payment enhancements that have expired. We also know that the revenue associated with the 340B program continues to decline federally. And I would say that one thing that's probably different about Vermont is we tend to have a greater reliance on that 340B revenue, just because such a high proportion of our hospitals are critical access hospitals. The higher than average inflation is something that everyone's feeling, especially when it comes to labor, though as we covered, that is appearing to slow. The cost of pharmaceuticals, difficult to control. And one thing that might make that better for a hospital is their leverage in a negotiation. And since Vermont hospitals tend to be smaller, there might be an additional challenge in the negotiation leverage there. The ability to attract and retain staff is a common theme across the submissions. I would say that in the Bureau of Labor Statistics data is a bit lagged, but just in anecdotally talking with CFOs, chief financial officers, that they're feeling a real shift in Vermont being a more local or regional market to really being national in their competition for staff. The ability to discharge people to post-acute facilities is also something that we're seeing nationally. I would say just because our supply starts off lower in Vermont, that there is probably a more dramatic impact locally. And then again, we just have a very high proportion of rural providers. So anything that's affecting that segment is going to be felt more acutely here in the most rural state, or one of the most rural states. So we are working on improving the hospital budget process. It is a process to improve. So this is a step in that direction, but it will take a few years to continue to enhance that. We are folding in some new publicly available data sources so that we can better understand how Vermont hospitals' expenses are growing compared to what has been seen historically and nationally. I would say that what we have targeted to enhance in fiscal year 25 and beyond are more kind of direct applications of quality, productivity, patient access, equity, consumer affordability, and per capita budgeting. So those are all ones that we may talk about this year, but haven't been as formally addressed in the expense factors as we hope to evolve to. I think we've talked about this ad nauseum, but the fiscal year 24 budget guidance inherits a benchmark from the fiscal year 23 budget. That 23 guidance established a 2-year benchmark. And so this year, that means that NPR growth from the fiscal year 22 actuals to 24 budgets of no more than 8.6%. We talked quite a bit in the reconsideration about how that is an ambitious target. And as a reminder from where it came from, when the all-payer model was negotiated, the theory was to keep healthcare total cost of care growth more in line with gross state product. So depending on the length of time and your look back when that was negotiated, that historical growth was between 3.5 and 4.3%. That has not been the trend that we've experienced in recent years, but it felt important to have something to compare it to that comes from a state objective or a state priority. And so that is where that 8.6 comes from, is 2 years of that maximum growth. So we do see here, and that by and large, we see some improvement in our hospitals. So if you look in the operating margins, most but not all have shown some improvement between where fiscal year 22 landed and where they are through June of this year. Again, we saw that trend in the national context, so that's not necessarily a surprise. And we see that in some cases that we are seeing also the rebound of the total margin. So the operating margin is just looking at the operating expense compared to operating revenue, whereas the total margin is the whole enchilada. We're still seeing pretty lower levels of days cash on hand, which is what DCOH stands for. So we see kind of a mixed bag there. Cash is something that can be helpful, especially if borrowing is expecting to be more expensive in future years. And as existing debt service coverage ratios have been depleted, we have more than one hospital that has violated some debt covenants. And so some of the metrics that they're held to have been adjusted to make sure that they have more liquidity. So they have more cash, helps reduce any risk that the borrower might feel. So when we look at the submissions, we've got 3 columns here. We've got what the submission looks like for fiscal year 24 as compared to the 22 actuals. We have how the 22 actuals are looking for 23 projections to date, and how those actuals compare to what was approved. So this is just telling us for revenue, our hospital's kind of on budget or not. It is so as a system, the 22 actuals to the 24 submission grows by 19.1%, with actuals to projected year to date expecting to grow 11, which as a system, we are what you would say under budget, but the system doesn't have a budget in and of itself. And you can see for some hospitals that they are more than 2% over or under the budget as submitted. So we see most are over, and one that is under from those projections for the year to date. Or I'm sorry, projections for fiscal year 23. Just a reminder, net patient revenue is revenue from all payers. So this is going to include Medicare, Medicaid, commercial, self-pay, workers' comp, all that good stuff. And so I think that as we evolve and think about expenses instead of revenue, these numbers in and of themselves require a little bit more investigation, right? So if we look at operating expense growth, you'll see a much different story where many hospitals are over budget. So they, in good faith, set targets for their operating expenses, but those can have continued to be a challenge in the current fiscal year. So we see that while the system as a whole intended to grow by 2%, the projection is more like 5.6% operating expense growth. Now, operating expense growth, just like operating revenue, has many components. So just looking at these in and of itself doesn't tell the whole story. And that's part of what the budget process is designed to do, is to learn more about these pressures and how hospitals are dealing with them. And try to get a sense of the amount of expense that is controllable. And I think that's a healthy conversation to be having. But you can see that any number is going to be, the smaller the number you're dealing with, the more dramatic a proportion can seem. So if your income goes from $1 to $2, that's 100% growth. If it goes from 100 to $101, it's a 1% growth rate. So that denominator matters. So I would say that, you know, when you look at some of these numbers, one question I always ask myself is, how big is that number to start? And so then rates is probably one of the things that is of most interest in the proceedings this year. So we're trying to get a better sense of how gross revenue or charge master changes relate to what happens to commercial net revenue. So the charges are that, if you look at your explanation of benefits, you'll often see a charge number that is a very high number, and you'll see a second number that is the negotiated amount between your insurer and the hospital, for those of us with insurance, which I know is not everyone by any means. So that charge master has gotten further and further away from the actual allowed amount. So we needed, I think it would benefit our regulation to have a better grasp of that net amount versus the charge. So we see that that the average 2-year growth in that net commercial revenue varies between 5.6% and 2.8% and 14.1%. So that's just taking the growth in the actual to from the fiscal year 23 actual to the fiscal year 24 submission, what it looks like the estimated commercial effective rate looks like from fiscal year 23 to 24, and averaging them with a simple compounding annual growth rate. So you'll see some discrepancy between the charge and the net revenue columns. In most cases, we would expect to see the charge master grow more than the net revenue proportion. So remember, it's usually a discount over off the charge, but that hasn't been the case for some hospitals. So that's another topic of conversation that we'll have during hearings. And want to note that the numbers here for Gifford are for just the expected growth from 23 to 24. Due to the work they've been doing on their charge master and in implementing their EMR, they have not had an opportunity to implement prior approved rate increases. So when you look at the actual numbers, they're going to look a little bit different than this because of those adjustments accounting for previous years. Also of note is, while we did in our findings of fact last year get an estimate for commercial effective rate from all hospitals, that's not been something that's been historically ordered for any hospitals but the UVM Health Network hospitals. And just as we learn and grow, one thing that I think we need to try to wrap our minds around is a rate that an insurer is thinking of is not the same rate you're seeing here. And so we'll talk a lot about that in the process this year, and how we can kind of try to be measuring the same thing across those processes, or similar things anyway. So as far as operating margins and total margins, so we can see, again, there were only a handful of hospitals that were able to complete fiscal year 22 in the black, meaning they had a positive operating margin. We do see that improving in the projections for fiscal year 23. And, you know, all but one budget is expecting to have a pretty modest margin. Now, this is a place where Gifford stands out again. And as we'll talk about in their hearing, they are in a pretty unique situation in that they are owned by an FQHC. which there's maybe, I could probably count on one hand how common that is in the United States. So their consolidated margin looks much different than this one. But other than that, the only other margin we see coming in above 3% is for Porter. And total margin again, there we only saw 3 hospitals finish profitably in the marginal sense in fiscal year 22. Projections look much rosier with only, looks like 1, 2, 3, 4, 5 hospitals projected to finish in the red this year. And budgets, seem to show expectations that continues to improve from what they submitted. All right, so we did outline a lot of data in the guidance this year. And so to try to distill all that information in one actionable place, we are using a budget review tool. We will be going through that in a moment. Might be helpful to get some questions before we change screens here. But I just want to be clear that these are new metrics. They're designed to be conversations. Every data source is going to have its strengths and weaknesses. And so, I mean, this is just me, but I think leading with curiosity and trying to understand is really the name of the game this year, as we all look to improve our processes and understanding of the budgets as submitted. So if it suits the chair, I can take some questions now before we move on to the tool, or we could just hold them till after that.
Why don't we do some now if any board members have questions? I don't have any myself, but if anyone else does, please go ahead.
Sarah, I just have a quick one. I think it was on slide 18, the days cash on hand for Springfield had an NA. Is that coming soon?
Yep, we're working on getting the rest of that information. Yep. Mm-hmm.
Okay, great. Thank you.
Yeah, no worries. Yeah.
And Sarah, I just have a quick question. On slide 6, you talked about medical care inflation, and on slide 13, you talked about consumer inflation for medical services. And I think part of what the difference is you have a compounded versus a annualized rate. But are those the same
they
things
both
just
come from
looked at differently, or yeah?
Yeah, they're both CPIU or consumer price index measures. I didn't go to see if they're including all the same things in medical across those two. So that other chart would break out the medical care services, whereas this has combined medical services, commodities, equipment, and drugs.
Okay. So on the other graph, which doesn't go to 23, but this one does, we might expect that line to plateau for a year. Okay. Just thank you so much.
Yeah.
Okay, great. Thank you.
Wonderful. So give me a moment I'm going to turn off my camera and share my browser so we can look at the budget review tool. I want to first and foremost thank everyone for their patience. The flood did postpone the launch of this more than I would have liked. So here we are, though, with our tool. And what
Sarah,
I'm going to
sorry, may I just interrupt? Is there a possibility that you could blow it up a little bit? Is it possible to have?
This is as big as it's going to
Okay, sorry, just thought I would check.
No. Yeah,
no worries.
Okay.
Keep going.
Yeah, no worries. Yeah, Tableau is not as responsive as one might hope. At any rate, so our intent here is not to look at any specific hospital, but get a sense of the measures that are included here and why, and give you kind of a forecast of the information that we will be discussing. So this overview tab shows so the green check corresponds to those filings that were on time and complete. So most hospitals were. There were a few that we had some delays in getting the complete filing in. And on the left-hand side, you can see how the change in NPR is between the fiscal year 22 actuals and the budgets as submitted. And the right graph is summarizing it for the change in operating expenses. We don't have an explicit benchmark for operating expenses. However, as we look to flip kind of our focus from a revenue to expense basis, I think it's good to start thinking about that sort of thing. So you can select a specific hospital with this drop-down menu. You can filter for just a specific type of hospital. And you can also filter based on network. So if you just wanted to see the Dartmouth affiliated hospitals or the UVM Health Network affiliated hospitals. And so in the table, these are the values that are graphed in the left-hand visualization. These values in the operating expense column are graphed on the right-hand viz. And then we have a summary of the charge master increases in aggregate from fiscal year 23 to 24, as well as the estimated commercial effective rate from 23 to 24. So that's a comparative snapshot of the submissions for folks to take a look at. And in the budget tab, we have for each hospital, we have the NPR target, whether or not that is within the 8.6 over 10 years, notes from the narrative, and then some staff notes where applicable. So each expense factor is summarized for net patient revenue, operating expenses. Remember, we don't have a benchmark for labor. What we're looking at is the per FTE growth over time. Utilization has to do with the change in adjusted discharges over time. Pharmaceutical expenses are what we've got in terms of historical information on the expenses as reported in adaptive. Cost inflation is meant to be non-pharmaceutical expense growth, and then the commercial price is our estimate of that effective commercial rate. Again, not an explicit benchmark on that factor. So for financial information, we are showing the change over time between NPR, which is the orange line, and operating expenses, which is the blue line. And then we also have some key financial metrics. We've got the total margin, which has been pretty bumpy in recent years, as well as the operating margin. We also have the operating EBITDA margin. EBITDA stands for earnings before interest, depreciation and amortization. So that's kind of a clean apples to apples look at profitability. And then the days cash on hand. So, you know, for Southwest, we know that their structural relationship means that much of the cash is held at their parent organization. So seeing them in this red zone is a little bit different than any other hospital. And we'll talk more about that when they come in. So the labor tab is showing that's not a good example. It's showing so what the per FTE compensation was in 2017. And this benchmark is showing us if we just advanced that value by the employment cost index, which is what Medicare uses for its you know, expense growth on that side, where that would be in fiscal year 22 and where the hospital is landing. And we can see also how the full-time equivalents have changed over time. So notably, this is just salaried employees as reported to us in adaptive. There are cost accounting differences that we might be talking about in hearings. And we also, so as an example, Gifford's done some dramatic reorganization in recent years. So we'll have, this probably is not a very meaningful chart for them over time. And, you know, for others, it probably is. And so that's the intent of that tab. Utilization. Here we're looking at how things change together. So how are changes in utilization changing compared to net payer revenue? So we don't include any graduate medical education or DISH. This is the amount of money paid by payers to the hospital, be it through claims or fixed prospective payments. We also see how that changes with operating expenses. So, depending on your size, some of these lines are going to look bumpier than others. And on the bottom, we have the emergency department utilization over time sourced from our hospital discharge data set. So that data is provided by hospitals and has been provided since, I think, the 1980s. And so it's a nice kind of consistent data set. And what we see here is the outpatient ED utilization proportion and those who are admitted. So if we're going to talk about potentially avoidable use, we would expect that to come out of this gray bucket. And when it comes to migration, this is, again, going to be a conversation as no data source is perfect. But what we have here is for inpatient on the left and outpatient, what those discharges have looked like. So we only have anything that would touch a facility claim or a UBO4 as we call it. And then what proportion of those discharges or that utilization is coming from the hospital's HSA and what is coming from outside the HSA. So that's the in-migration. And so, you can see that these patterns are going to look a lot different for a border hospital versus someone that is less close to the border. And then you might see people traveling for tertiary care as well. So say a UVM. And then on the bottom, so now we're not talking about utilization, we're talking about dollars. These are claims-based dollars as they appear in our all-payer claims database, which is not all the dollars by any means. So first, these are only people that have Medicaid coverage through the state of Vermont or Medicare coverage through the federal traditional fee-for-service, as well as this also will include Medicare Advantage business. So that we get in VCures. And then the commercial market is the one where we have the most questions. We know that we're missing a little over half of self-funded business at this point, which can be quite significant. We also won't have anyone with military coverage called TRICARE. We won't have federal employees in there, and also anyone without insurance or anything paid through workers' comp or other third-party liability insurance. So, but of the information we have and how it looks over time, we can see for a specific service area. So for folks with a mailing address in the White River Junction service area, we can see that most of those dollars are not staying in that service area. So most of those dollars are leaving, and you can further kind of look at it. So, well, is it any different for just professional services on those CMS 1500 claims versus inpatient or outpatient facility? But we'll see that that can look very different depending on the HSA. So this is getting a sense of folks who are traveling for care. The cost report is probably one that will have the most to learn. So how these things are different, but these are a summary of many of the gold standard metrics that Mr. Reese presented a few meetings ago. So we have a peer group flag. So you can look at, mid-sized rural academic members of the Association of American Medical Colleges, mid-sized rural hospitals or critical access hospitals. And you are able to kind of highlight the Vermont hospitals when you click on the orange part. And you can see how they're performing on these metrics. As a quick reminder, so adjusted discharges is our measure of size. That takes the inpatient discharges and scales them by the ratio of inpatient and outpatient revenue. Charges. We also have the Medicare case mix. So as a reminder, when you have inpatient care, and Medicare is paying you, it's often what's called a DRG payment, or a diagnosis-related group payment. And each of those payments has a certain weight associated with the resources involved. So open heart surgery will have a much higher weight than an outpatient visit, say, or you wouldn't have that in inpatient, pardon me, but for, say, colonoscopy. So we're going to have much different weights. And so that's giving you a sense of, so here at St. Joseph, they have a much higher patient acuity than they do here at whoever's on the end here, Newport Hospital. So that's just a range of the inpatient acuity of patients. The ratio of administrative and general salaries to clinical salaries. So that is taking just the admin and general line from the cost report, which I'm with Mike, I think that's line 5. And then comparing that to the salaries paid for inpatient routine services, outpatient services, ancillary services, essentially lines 30 through 100, whatever. So what that ratio looks like, this is one that we have a lot to learn. This is going to be really sensitive to the corporate structure of the hospital. It's not designed to reflect the expenses associated with owned physicians. That's something that we would want to look at the Form 990 to get a better handle on. But I think really what we're looking for here is how we can think about creating a reasonable, comparable index for this. So this is kind of our first stab, but I think we'll be able to further improve this metric over time. Cash for operations. Just a note here that, despite the cash listed here, some of that might be restricted. So sometimes you'll get a donation that can only be used for certain things. So that is, again, a conversation that we'll be having. The EBITDA, so we talked about EBITDA earlier. This is adding also expenses associated with rent, and seeing this is going to be our closest thing to a profitability metric from cost reports. And then the CMI adjusted cost per adjusted discharge. So this is taking from MedPAR, which is Medicare fee-for-service claims, taking the average cost. So they use the cost to charge ratio for that cost center and allocate the expense that way. And we scale that by the case mix index. So it tries to get as apples to apples as possible for that cost per discharge. Again, we'll have a lot to talk about. Notably, this is only going to be Medicare fee-for-service claims, and Vermont is relatively late to the game when it comes to Medicare Advantage. So some things we see here might be more related to that than anything else.
Hey, Sarah.
All right. Oh, yeah.
Yeah, sorry. Before you move on, could you explain the dark square, the light square, and the lines on each of these, please?
Sure. That's always good. I forget that not everyone loves box plots like I do. So this is a box plot. It is a way that nerds like me like to look at the distribution of data. So these dots are the distribution of the data points, and this box is helping us summarize it. So the line between where the light and dark box is what we call a median, which says half of the points are above this line and half of the points are below this line. So it's a measure of position, which means that we're not going to get dragged around too much by outliers. So with an average, if there are 5 people in a coffee shop and one of them is Bill Gates, your average compensation would be way bigger than your median, right? So that's what we're trying to do. And then when we go down to the end of the dark gray box, that's our 25th percentile. So that's where 25% of the observations are lower than that and 75% are higher than that. And then we go down to the lower whisker, which in this case is the 3 times what we call the interquartile range, which is the value of the middle 50% of the data. So here's our 25th percentile, our 50th percentile in the middle, and the upper end of the box is our 75th percentile. So that's where the middle 50% of our data is. This is what 1.5 times that range looks like. Anyone above that might be considered an outlier, or in some cases an extreme outlier. All right, was that too fast or picking up what I put down? Okay, great.
Thank you.
All right. Yeah, no worries. Thank you. I totally meant to cover that. All right. And then so cost coverage, this is one that probably will take the most thinking to digest, or it does for me anyway. So let's just start with inpatient care. So on the top here, and this is hot off the presses, fiscal year 22 data. So we have commercial, Medicare, and Vermont Medicaid. These are the primary payer, so who paid first. And we're seeing what the average payment was per discharge, or on the outpatient side, ambulatory payment classification service. So that is the average payment that was received. So you can see that commercial bars are higher than the governmental payer bars. So that is that difference in payment. And the bar is what Medicare says the average cost was. So much like the last tab, we apply the cost to charge ratio for the applicable cost center and figure out what Medicare thinks that cost. Medicare does not reimburse for all costs, so this is the Medicare allowable cost. And then above here, you can see what the payment is compared to that Medicare allowable cost. So we see for inpatient at Dartmouth, 68% of the Medicare allowable cost is covered for Vermont Medicaid, and 60% is covered for UVMMC. We see that UVMMC is providing a lower cost service, as Medicare would say, and that is true across payer types. And then what these numbers notably are not adjusted for acuity because this is what it's going to look like from a budgetary standpoint. Unfortunately, you don't get to risk adjust your payments. Well, sometimes you do, but that's not the norm today. And then here, what we see is what the cost coverage has looked like over time. And so here we see declining inpatient cost coverage from Medicare and Medicaid over time, and what that's done to the commercial inpatient rates. We can also see what that looks like just for the outpatient setting. And fiscal year 22 is a rough one, or was a rough one. And last but not least, we have tried to package some information from RAND in their hospital transparency study. And so what this is doing is taking standardized prices. RAND provides two numbers in their analysis. They provide the relative reimbursement compared to what Medicare would pay, and they provide this standardized price. So one kind of important note about Medicare is that they actually don't pay everyone the same. They pay differently based on several adjustments, and those are designed to reflect kind of the wage in the area and other factors such as your designation. So that denominator can change and kind of distort that relative comparison in some ways. And we have some notable changes in Medicare reimbursement due to the wage changes and some designation changes that mean I think the standardized price is probably a more valuable comparator. And so this is pooling data from 2018 to 2020. So it's very old. They're working on their next round. But I just think that it's important to note how dated this information is. However, you are able to, highlight either a Vermont hospital or a regional hospital, regional academic medical center. So you'll see, for instance, Albany Medical Center. So for each inpatient discharge, the commercial reimbursement was about $36,000, whereas their payment for per outpatient service was down at $192. So we see that they were below that 25th percentile when it comes to the outpatient reimbursement, but above, quite far above the 75th percentile for the inpatient care. So that's what I got. I can leave this open if there are any questions or more details that would be helpful. We'll have our first guest starting in 20 minutes. So want to be mindful if folks want a little bathroom break before that starts too.
Sarah, sorry to put you on the spot here, but the declining cost coverage, could you go to that again real quick?
Mm-hmm.
And to what do you attribute the declining cost coverage for our hospitals from Medicare and Medicaid, if anything, if you have any insights?
Yeah, so costs are accelerating faster than payments is kind of the short answer. And I think that even the Medicare allowable costs have not reflected the recent inflationary increases as much as one might hope if you're a hospital.
Okay. I didn't have any other questions. Any other board members have anything for Director Lindberg?
I don't
Great.
have a
Okay.
question, but I wanted to just say thanks to Sarah and the team because this is an incredible tool.
Yeah, I think we still need to try to find the forest, but we've got more trees.
I assume I'm going to have questions over time as we get into individual cases. So, but thank you so much. I mean, this is a heavy lift and super helpful. I think this is going to help, as you said, generate a lot of conversation and knowledge.
Great. Well, we'll give you ourselves a 19-minute break. We'll be back at 10. And thank you very much, Sal, for all of this great effort. See you soon.
Sure.
Thank you.
Okay. Sal, can you hear me okay? Great.
Yep.
All right. Looks like we have everyone here. And so we are now turning to Southwestern Vermont's budget presentation. And I see Mr. D here. Welcome, Mr. D. Nice to see you.
Thank you.
And thank you for your submission. I'm going to turn it to Mr. McCracken to swear in the witnesses, and then you could proceed. And thanks for being here.
Okay, thank you.
Good morning. So who from the Southwestern team is going to be presenting and answering questions today?
Well, it will be a team approach. Steve Majetic will be our facilitator of answers, and other individuals will also probably respond as requested by him.
Okay. If for anybody who's going to be presenting or answering questions, I'd ask that you participate in the swearing in, but we'll do everybody at once here to make it easy. So if you could raise your right hands. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
I do.
I do.
I do.
Jim Roy?
Great.
Yeah, I do.
All right. Well, thanks very much. And I believe the floor is yours.
Okay, well, thank you very much, Chair Foster, Mr. McCracken. And thank you for the opportunity to make some brief opening comments. I'm Tom D. I'm the President and CEO of Southwestern Vermont Medical Center. And let me just quickly introduce our other representatives here who will be making comments today. We have Kathy Fisher, who is the SVMC chair, board chair. We have Stephen Majetic, who is our retiring CFO, but has stayed on to help us on this process here. And we have Dr. Trey Dobson, who is our Chief Medical Officer of the hospital. And also we have Jim Roy, who is our interim CFO and controller. So that's the team who will be talking today. And again, I just want to let you know, certainly I've been in healthcare management for over 43 years, 33 of those years as a hospital CEO. And I must state, and I think the panel members have indicated too, this is one of the most difficult times of my career. SVMC has been adversely impacted by many of the similar forces that you will be hearing about during these upcoming budget hearings over the next few weeks. The workforce shortages, inflationary pressures on all our expense items, drug costs and supply shortages, insurance company denials, third-party reimbursement reductions, especially in the areas of 340B, skyrocketing construction costs, and our inability to refer patients to the appropriate level of care outside of our hospital, all are impacting our day-to-day operations in a very significant way. SVMC has been fortunate. We've experienced 12 straight years of positive operating performance, but unfortunately for us and our community, that streak will end in 2023 with our first operating deficit. But as we look toward the future, we continue to work on transformation and reforming how we operate. We're starting a new era as a member of the Dartmouth Health System. And as we enter into that new arrangement, we're looking forward to focusing on the following. We're going to certainly one of our top short-term objectives is a transition back to a positive financial performance. As you know, in our budgets, albeit it's a small operating gain, but our hope is a transition in 2024 to back to a 1% margin, and in 2025 is our plan is to work on getting back to where we have been historically, which is in the range of 3%, in a range which we feel is for non-for-profits, that is a spot that we need to be in. We're also looking to improve on patient access with a particular focus on primary care. And we'll talk more about that. And we're looking to continue to pursue opportunities to reduce healthcare costs and at the same time improve patient outcomes. And we'll continue to pursue our initiatives that has allowed us to just recently become a CMS 5-star hospital. We are striving for our 6th consecutive nursing magnet designation that will be coming up in the near future. We're trying to continue our designation as a leapfrog A-rated hospital for patient safety, which we are right now, and trying to build on our American Hospital Association national recognition for leadership and community collaboration. All very important initiatives for us to be a successful, sustainable healthcare hospital. Our strategy is to reduce patient outmigration and to facilitate Vermonters to receive more healthcare locally. As our experience and our data shows, as people leave our region and go outside our region for healthcare, especially to other states, it costs the system and Vermonters more money, and we think we can provide care at a more cost-effective level and at a high quality locally. Our vision is to transform SVMC into a regional referral hospital in the DH system, and as we take on that planning task, we're going to focus initially on the following services over the next few years, looking to expand our regional oncology services as a key strategy. We're looking to continue to develop our cardiology services and transform them into cardiovascular program, which will be a more extensive program for our community. We're looking to strengthen and diversify our surgical services. We certainly provide, I think, solid services, but we don't have the depth to allow people to stay local, and that's our goal. And clearly, probably our top priority is to expand and promote primary care. I would like to ask Kathy Fisher, who I thought it's important for the board to hear from our volunteer leader from the community, to take a moment to talk about the board's rationale for us to become part of the Dartmouth Health System. So Kathy, could you join in?
Yeah, thank you, Tom, and thank you, Chair Foster, for this opportunity for discussion. As Tom said, we've had a lot to be proud of at SVHC over the past 12, 15 years. We've had repetitive awards for our quality of care.
I'm sorry, Ms. Fisher, I missed all the first half of that. I'm having a hard time hearing you. Maybe if you're not speaking, could you mute your microphone? Thank you, Ms. Fisher. Apologies.
Can you hear me now?
Much better.
Okay, great. I'll lean forward a bit. So I just say thank you for the opportunity for this discussion. And as Tom said, we at SVMC have had a long track record of success. We've been recognized for the quality of our care. We've had a strong balance sheet, stable margins until the recent period. But as our board looked ahead during the 2010s, all the issues that we've been discussing today were clearly visible. Our aging demographics, a population that needed more services, and also the drug addiction problems and mental health problems that have affected families so significantly. At the same time, the problem the Northeast has had the Northeast New England has had in attracting doctors has really become a national problem. We could see that we were competing nationally for doctors much more than in the past. And of course, after COVID, the staffing shortages have been quite stunning up and down our organization. So we thought about all the ways we could improve how we provide extra care, increase services without increasing costs. And we have been working with partners in the local area for things on mental health, for example. But the opportunity to merge with an academic medical center, in our view, really would be the best way to provide the breadth and depth of services we want for our community without substantially increasing costs. And Dartmouth to us turned to be we think the very best partner. We knew Dartmouth well. Our doctors had worked with them for 10, 12 years in an affiliation relationship. And we spent a lot of time looking at their system, how they run their health system. And what we could see was that their interests are very aligned with ours. They understand rural healthcare, obviously, but they have increasing demand for critical care services, and therefore it behooves them to preserve their bed capacity for critical care. And as Tom said, have SVMC provide more primary and secondary services to our community so that we're not sending people there as much, but rather doing things in the local community to provide things right there. With oncology having huge demand from our base and cardiology services as well, those are the first things we're focusing on, but others as well. And the idea of providing local care has been very much embraced in our community because people have been traveling outside, and the more we can do, the better the outcomes will be for our community. We also want to lever the expertise that DH has in areas that we don't. For example, psychiatry. Again, a very significant need in our community now, and we are actually working with the state to assess the feasibility of providing an inpatient adolescent mental health care facility where DH psychiatry would be the provider on that score, but we would be actually having a facility at our hospital. Look, there's no magic bullet to any of this. We know, Dartmouth knows that there's just a ton of blocking and tackling that has to be done. But an advantage of the system is that sharing best practices is a real opportunity. And I'll have to say on our side, one of the things that we've talked about a great deal with Dartmouth and others is how we have retained our nursing staff through the pandemic, which, as you all know, has been an incredible challenge. And it's not just money. It's a lot of cultural management through our really terrific team headed by Pam Duchesne, where we've really empowered our nursing staff to lead and take on roles and to make sure they're getting the career development and the input that gives them, I think, much better job satisfaction than they might get elsewhere. And as you all know, working in a hospital now is a very challenging endeavor. Workplace violence is not something most people ever signed up for. So we really take it very seriously that we have to hear our employees and what we can do to help them to get through a much more challenging time than they ever would have expected. And I think that's been a really important contribution to how we've kept our high quality staff and maintained high quality services in a cost controlled way. So I'll leave it at that, but say, as Tom said, we're looking forward to an ongoing evolution. And we fully appreciate that for the system to do well, all the members need to do well, and vice versa. So it'll be a very integrated effort going forward, and one that we think will really help us to provide more and better services locally without taking on significant additional costs. So thank you very much.
Thank you, Kathy. And as Kathy indicated, I think we believe our integration with Dartmouth Health will create additional operating efficiencies, and over time will assist us to better control healthcare costs. It's going to help us in an area that we all struggle with in rural Vermont and other rural areas is scale, which is oftentimes the missing element in the operations of rural healthcare institutions. Through joint purchasing and supply chain opportunities, implementation of shared services, and a great example which is going to help us is the implementation of a shared IT system with Dartmouth Health. They will allow us to expand and make more sophisticated our physician practice support, which is certainly a bedrock to our future operation. and it will create additional administrative savings. And I think this is a strategy that will help us to become more cost effective. The cost of insurance, the cost of financing, and executive overhead. You know, as you look at these organizations, our organization, you know, we have an overhead which over time is expensive, and we think moving into a system creates an ability for us to do a couple of things. One is to certain positions now will be handled at a corporate level, not at our level. And that will allow us to reduce certain executive positions and the type of individuals that we need to recruit. From my position on down, over time, when you're part of a larger system, you can you look for a different skill set. You look for people who can be earlier on in their career, have up and coming high potential, but don't have the you know 20, 25 years of experience that oftentimes you pay for. So we think it's a exciting opportunity for us to recalibrate and to become more effective with the strength of a system behind us that has a great deal of intellectual capital as well as resources. So these are not easy decisions to make. I mean, this is, you know, we've had 100 years of I think, you know, pretty good success at SVMC on our own, but we think working together in this environment for us, and every community is different, but for us makes the most sense. And with our continued mission to provide exceptional and accessible care, and Kathy talked about the two examples, which is driven both by our board's commitment and the relationship at Dartmouth Hitchcock Medical Center is, as Kathy said, one is on the mental health side, which is a service that most hospitals would not be looking to jump into during a time of fiscal challenges, but the provision of both inpatient and outpatient adolescent services is a huge community need that our board has indicated is a commitment we need to go after. And we are focusing on that, working closely with the state as a partner to try to make that happen. And the other area I just want to quickly mention is the strategy to expand primary care, which is another huge issue that's facing us as well as the rest of the states. And maybe I can ask Dr. Trey Dobson, who's our Chief Medical Officer, just to comment about our strategy in the primary care market. So Trey?
Sure. Well, the first that you would have noticed in the write-up is to try to increase access now in our own system without the time it will take to build out primary care. So we're doing that. You know, we're doing it with things that you've heard about, using scribes to help make the efficiency of the physicians and advanced practice providers better. We're doing things like having staff prepare the charts ahead of time, which you may think doesn't add much, but it adds tremendous amount. It means that the doctor or the nurse practitioner doesn't have to gather a bunch of information before or after they see the patient, that it's all categorized into one container. And we believe we can increase the access through primary care, but around 15%, between 12 and 17%, just with those initiatives alone. We started those in April, and we're over 5% now, so I think we're well on our way to increase in that. But the long term is different. So we have two main things we're looking at. One is to really open an additional practice and bring in new advanced practice providers who are right out of training and have physicians and experienced advanced practice providers mentor them, you know, not take on a full patient population, almost like additional training. Why that's important is we actually receive lots, I mean, a significant amount of CVs from an interest from new nurse practitioners and physician's assistants, but they have very little experience, and that has been worsened by the pandemic because their clinical experience is really less. They've done a lot of online training, but they don't have that patient encounter background, and they say it right off the bat. They say, who's going to support me? And when we don't give good support, it's not good for the patient, but it's certainly not good for them, and you see a high turnover rate. So we're starting that now in 2023, 2024, and then also the planning for the family medicine residency. This will be a very big lift. It's going to be a large initiative. It's going to take hands on deck. We think it's the right thing to do. We've got a lot of support from the public and from our physicians and nurses to get this going. It's not as easy as just setting up an office and recruiting in residents. It's much, much more difficult than that. And I think many of you probably know that. There's a lot of competition between residencies, and you have to do it right. So we're either going to do it right or we won't do it. And the answer is we'll do it right. And happy to take questions on that now or throughout the session.
And just to add to that, we could not do either of these two services on our own. I mean, the need for an academic partner to be successful in the mental health area, especially with physician coverage and physician direction, and the fact that the training program would come under a Dartmouth sponsorship, which make it critical for us to be able to recruit residents. So we thank you for the opportunity to be here today, and we welcome your questions regarding our 2024 budget submission, and I'd also pass it on to Steve Majetic, who will help facilitate the Q&A session. So thank you very much.
Well, Tom, I think I'm going to hand it off to Sarah, correct?
No worries.
I have no additional comments on the overview, but so I'll hand it off to Sarah, and then after your presentation, Sarah will take questions.
Yeah, I think we'll kind of be having a dialogue as we go along here. So I'm just restricting to kind of PPS hospitals. We see that your budget comes in just above that benchmark, which was impressive given the expenses associated with increasing the access, as you just detailed for us. And noticing that the expense growth, despite those enhancements, is below, the revenue growth expectation. So I think that's just notably impressive. So want to flag that for folks. And let's get into it. So I think you highlighted this. Some of the plans for increasing access include the primary care and the oncology and cardiology services. And wondering, you highlighted how AHA has historically, or you've gotten accolades for your community collaboration. I'm just curious how you approach that process and how that affects kind of the decisions for the infrastructure you do invest in.
Is that a question?
Yep, that's a question.
Okay. Go ahead, Tom.
Yeah, maybe initially, I mean, Sarah and the board, we very seriously take community collaboration as an institutional priority. And actually, it was one of our strategic initiatives is creating critical partnerships. And we have formed a large group of organizations that we meet with every month. And there's up to 25 organizations that are in this group that we sit down and we talk about healthcare issues, social determinants of health. And we don't just talk about a hospital. We talk about the healthcare needs of the community and how we can all work together. And we've hired individuals who help facilitate that process. And I think we have a philosophy that's the hospital should not dominate these discussions. The hospital has to help facilitate and be part of it, but to work with the community organizations and non-for-profits, physician groups to try to solve these issues together. And it's a challenging process to go through, but it's one which we think it serves the basis for a very, I think, fruitful relationships in building one of trust and collaboration, which for us seems to work.
Wonderful, thank you. And could you help us understand which ACO programs you're planning to participate in fiscal year 24?
So Sarah, in the ACO will be in the Medicare, Medicaid. We saw a drop. One of the questions we got was why did our fixed prospective payment numbers go down? It's because of the elimination of Blue Cross. Because we were in the Blue Cross model and Blue Cross is withdrawn, but we were one of the first to be in the Blue Cross, and now the Blue Cross is withdrawn. So it's the Medicare, Medicaid, and I believe that there's a small piece of MVP. but MVP is not a substantial driver for us in our region.
Wonderful. And sorry, I had the wrong hospital up there. So,
okay.
we are rounding to it is 8.96. I know that 8 is nice to see. So,
yeah.
And then, so no, I think conversation with you would be complete without understanding how you've been so successful in navigating the traveler expenses, and if you could just share some things that you find have been particularly effective in managing that very challenging expense.
So I'll defer to Tom on that one.
Yeah. Okay. Thanks, Steve. And let me just, this is a challenging issue, and it does vary by community. So each community is different on this. I mean, let me just talk about our philosophy here. And our philosophy, and we were challenged. We said, let's try to figure out ways of how we can incentivize our existing staff to stay, and to stay with us, and to meet the needs of our patients. I mean, we have a tremendously talented clinical staff here. We're blessed by that. And so we came up with, through our human resources, our nursing department, our physician groups, we came up with different structures of how we could create incentive arrangements, especially in our high areas of vulnerability, to keep staff here. And I think we were successful, and we said, let's try not to hire travelers. Again, and we also, we are in a non-unionized environment, so that gives us some additional flexibility to do creative things. And we were able to create a number of creative pay arrangements. But I have to say, Sarah, the most important initiative is a leadership that was provided by our nursing executive management team, which led by Pam Duchesne, Dr. Duchesne, and she took the philosophy of all nurses don their scrubs, and they come to work, including herself, every day in scrubs, and they work the floors wherever the need is. And we, and Pam, as an example, she would work night shifts, she would work evening shifts, she would help fill in. And I'm not saying that's a sustainable model for the future, but for us, it sent a strong message to our team that management is there with you, we have your back, and we're going to work with you. And her entire team took on that philosophy, working side by side by our other clinicians. And that had a tremendous impact and an influence on our nursing team. And so we were, we were very successful. I think for the majority of the pandemic, we had 0 travelers. We had to bring in a couple on the insular areas that were very, very small departments, 1 and 2 people. When we lost someone, we had to, bring in a specialist to help cover. But I think that was the approach, the philosophy of working together, and to kind of create a magnet moment with our team to say, we're all in this. And everyone worked hard. They were all very tired, but we tried to support them in every way we could.
Sarah, I'm just going to throw one more thing in too. We also very, very early in 2020 focused on staff safety and transparency, and very frequent messaging to staff. And I do think that provided some assurance that their colleagues at other locations weren't seeing. That came all from leadership, and then all through middle management and down to staff themselves. And most organizations eventually adopted that, but I think doing it early, gave some confidence to the staff.
Thank you. That's very helpful. The other question I had is, you are projecting a reduction in FTE slight from 820 down to 811. Just curious if you could give us a little more context about kind of the thinking in those positions.
So most of those positions, Sarah, are in administrative areas, not patient care areas. We looked at, every year when we go through the budget, we look at all 800 plus FTEs. Okay, we have a workforce steering committee, and we look at them all and we say, what can we do without jeopardizing patient safety, patient throughput, so we went through, and like I said, our workforce steering committee is very active, and we settled in on the 811, I don't know what else to say, is that, you know, we just keep looking for ways of reducing FTEs, because they're, you know, first of all, they're our biggest cost from you know, when you look at the people cost in the hospital. But we got to remember that we're serving people, we're treating people, and you know, we looked at every position, and we didn't want to jeopardize any costs, any patient safety issues, any throughput issues. So we settled in on the 811. It's a small decline of 9 on 800, but it didn't go up. And, you know, I'm the CF no. I always try, you know, we got to squeeze that. And the team works really well together, and they monitor the FTEs, and we see year over year. We usually don't have too many variances, but every once in a while we do. But this was a concerted effort by all parties.
And Sarah, just add to that, just one quick example, and it relates to systemness too, is that we lost a talented chief compliance officer, and who went to another institution, and we made a decision that we would not replace that position. We would move an existing person up, our risk manager, into that role, and we would use the Dartmouth Hitchcock compliance service to help provide the oversight in direction that we feel we would need. So that's, the system helped us in terms of saving an FTE position, in terms of a higher price FTE position too in our system.
That's a really helpful example. And just looking at this, kind of, you've almost exactly kind of managed to the employment cost index, which I think is a testament to how the effort that you put into managing and right sizing your staff. And I think I'm just curious what, if anything, might be changing in terms of the local control with the changes in your relationship with Dartmouth as it goes to compensation or other factors that affect labor.
So Tom, I'll let you touch on that.
Yeah, I think, you know, the philosophy of the operations on the DH system is that the system, the DH parent board, helps us set strategic direction on the bigger issues, the clinical side. The running of the operations is really vested with each hospital, and that was very attractive for us. So we have to manage to our budget. We have to make those decisions, and so DH does not get involved in that day-to-day operations unless we ask them for assistance in terms of some consultative work on a particularly vexing issue. But by and large, we have to manage it, and we have to, you know, kind of live with our budget projections, and again, we find that as an attractive feature, not a detriment.
Thank you. I think that covers the questions that are coming from staff. At this point, if the board has any questions specifically related to the labor expenses in the budget, this would be a good time to fold those in.
Sorry, Sal, do you want to do just labor, or do you want to do all board questions at the end, or by topic?
Let's try and stay within the topic so we hopefully can reduce the cross-referencing.
Great, okay, all right. Any board member questions?
This is Robin. Hi, all. I just had a follow-up on the discussion that we just had around the FTEs. Would you expect, I know you talked, Tom, about how the DH affiliation will help, and you gave us a good example. Are you expecting additional changes in the FTEs in the future as that affiliation comes to fruition?
You know, Robin, we will have changes because, for instance, I believe we'll start some new service lines that we've never had in the past. You know, an example is mental health. That is something that we are not licensed for mental health services. I know we had to go through a whole Green Mountain Care review, so I'm not taking that for granted. but if that's approved, that would be a new service line. The development of the primary care teaching program would be a new service line too, in terms of a teaching program. But I think there's other opportunities that would also create areas of potential shared services, both from, I mentioned information technology. I think there's opportunities in billing in the future, and that's something that we'll be talking about. I think there's certainly in our supply side, I think there's opportunities to share there. So, I mean, one of the initiatives is that's we come up with a shared services task force group that's being kind of run through DHSC. Where can we work together to create best practices and share our overhead and try to centralize if it makes sense?
Thank you. And I just had one clarification question from your narrative related to labor expenses. It's on page 6. So on the top of page 6, you have a paragraph about physician costs in fiscal year 24 are budgeted to go up a small amount in the scheme of things. Increasing access and throughput in the medical group is a significant driver in the 2-year increase of costs. And I just was trying to reconcile this with the reduction in FTEs. And I think what I heard you say is that most of the reduction in FTEs were in admin. So I just want to make sure I got that right. And if I was missing something, give you an opportunity to explain it.
Yeah, Robin, the FTEs are all administrative FTEs. And in the physician cost, there is an increase in providers, so we can improve the access, which accounts for a portion of the increase, as well as additional compensation for that increased workload that the physicians are doing. But to your question, they're non-physician, and they're all administrative type personnel.
Thank you. Those were my questions about labor.
Any other?
I have.
Go ahead.
Yeah, I have one or two. On your approach to the nursing situation, when did you start taking steps to end up where you are now, which is a pretty successful position?
Tom?
Okay, I'm sorry, are you relating to the travelers? I'm not sure I understand the question, to be honest.
Yeah, you described how there were some efforts to provide incentives to retain the nursing staff, and then there were some efforts to have some leadership working hand in glove with your nursing staff. And I'm wondering when did you recognize that you needed to take steps to shore up the nursing staff?
Yeah, very early on. And actually what was a driver was we had concerns hearing from our staff members about a particular service in the hospital, one of the departments, a very critical department for us, that there was some discussions about nurses going into taking traveler positions. And that was the impetus for us to say, okay, we really need to think outside the box here. I mean, we've had years of different type of arrangements and different type of strategies to keep nurses and recruit nurses, but this was something that was very significant. So it was early on in the pandemic where we said we got to change the model, especially from a standpoint of compensation. And I think we tried to, we're a small organization, so we were able to react pretty quickly on that.
Have any other Vermont hospitals, reached out to you to learn from the efforts you took to be so successful in this realm?
Yeah, we actually had a number of discussions with different Vermont hospitals, and actually other hospitals outside of Vermont who had heard about it. So we've had a fair number of discussions by institutions, and again, each region and hospital is different, and But so we've had those discussions, and certainly I can't speak more about the nursing leadership that helped to drive this.
I have no other questions, but I recognize and want to commend you for keeping those costs down. It's great to hear that you were able to control FTEs without actually impacting patient care. That's important, and great job on the nursing front. You should be commended for that. So thank you.
Yeah,
I have nothing else.
Thank you.
Other board questions related to the labor component of the submission that would help in your decision making? All right, any questions from the healthcare advocate about labor expense?
No questions at this time. Thank you.
Okay, great. All right, so moving on to utilization. In my judgment, a bit of a humdinger for budgeting purposes between your efforts to reduce inpatient utilization while also expanding some of these service lines. So I wondered if you could just, at a fairly high level, just explain how you went about budgeting related to utilization changes for 24.
So Sarah, what we did is we looked at our recent trends, and we believe that as we improve access and pull patients back to our service area who are now leaving, hopefully we can keep the patients healthy and reduce over time, because this is not something that could just happen over 1 year. Okay, this is something that will happen over time. So what we did in the 24 budget, we kept our inpatient utilization flat because we do believe we'll start feeling some of the efforts of improving access, improving the health status of our population through the access, and pulling back out migration. But I know people would want us to see that inpatient utilization go down because of that, but it's going to take time. So as we get more data, we'll be able to look at that, and possibly on our core business as we have today, maybe it will go down. But as Tom said, we're also looking to improve services because if we improve services, we may actually see that decline negated because we're keeping patients local. So we decided to take what I consider a conservative approach and be flat, because there's a lot of moving parts there that can drive it either way. And we'll see if we're right a year from now. And if we improve the access and we treat patients in the office and reduce. But as we're working with Dartmouth, we'll then see some improved services, which will probably bring it up. So from a budgeting perspective, we felt flat was a logical way to do it, and we'll evaluate it over time, just like we've done in the past, and see where we end up.
Thank you. That's very helpful. Apparently my filter is broken, so I don't see your ED utilization here. It was old anyway, so we'll get that fixed.
Our ED utilization is also flat because, ED utilization, one of the things that we didn't put in our narrative, we did put it that we're in the middle of this ED modernization project, but there is some thought that people may want to come just to see it, okay, and not for a visit, just to go through it. A couple other hospitals that did new EDs saw an upclick in the first year or so in it. So we didn't factor that into our budget, but we kept it flat, and over time, hopefully we can reduce that. But again, it's one of those balancing acts as we improve access, because access is not going to drive those decisions people make like that. It's going to be, as Trey pointed out, we're at 5%, we're moving to the 10%, then the 15%. It's going to be a gradual. I think 2025 we'll have a year's worth of data underneath that we'll see the impact, and we'll be able to measure it much better. Trey, I don't know if you'd like to add anything.
Yeah, it's a little bit of rolling the dice. I don't know, making some projections with a blindfold, because as we increase access in primary care, the hope is that you keep people healthier, they don't go into heart failure, and they don't therefore need to be admitted to the hospital. But at the same time, we transfer a lot of people out for things that can be done in a community hospital. ERCP, for example, which is helping to help with a gallbladder attack. Mild heart attacks, things that can stay in a community hospital if you have the resources and services to do so. And we know that we have those patients. We know we transfer them out. They go to Albany, and we just saw an hour ago how expensive it is to be an inpatient in Albany. And that shouldn't happen. We should keep people here, and we need those services. Cutting those services doesn't decrease costs at all for Vermonters. In fact, it increases, and I'll argue that over and over. Then lastly, there is a distribution need in the state as well as in our Dartmouth health system, and that distribution needs to make sure that beds are being utilized appropriately, and we're available to have patients that can't get into other facilities. That is a problem. So balancing all of those variables, we came up with a flat 0% change, and we'll see how it goes.
Yeah, thank you for that. And I'm just curious if you formally track what we think of in the policy world as potentially avoidable ED utilization, and if so, or if not, why not? If so, how you kind of approach that?
Trey, you want to take a shot at that in the ED?
Yeah, we do. We don't have
You also work in our ED. You're an ED physician by training, and you currently continue to work as an ED physician. So go ahead.
Right. So I work half-time here and half-time at the academic center at DHMC. So I do get a little bit of a perspective there. We do, Sarah, I think Sarah asked the question. We use a couple of standard metrics that probably, David's aware of. I can't even remember the names of them right now. They come basically from claims data, insurance data. I have to tell you, I want to follow them. I want to give them the worth. I don't believe in them very much. They just use diagnosis codes. For example, sore throat is listed as something that's an avoidable emergency department visit. Most of the sore throats that I see, and this is true because I work in an ED, not in urgent care, and we do have an urgent care that sees minor sore throats. The sore throats I see need to be in the emergency department. So excluding them as a avoidable, it just doesn't make sense. Another one is headache. Often headache is listed. So I don't want to go back and forth on that, but we try to follow those metrics. I will say our throughput in our ED and our numbers, the reason they have slowed a bit or leveled is because we have an urgent care that now has higher volumes and sees much less sick people. So most people that come into the ED at SVMC are now much higher medical need than they were when I started here in 2005.
Yeah, and I would just say the data certainly bears that out, that DRG severity has been creeping up across the country. So not just in folks' heads, I don't think. The other question that I had, and now that you're a short timer, maybe you can share some of your secrets here, Mr. Majetic, but it's clear that you do have some initiatives to increase productivity. You talked about kind of getting charts set up for providers and whatnot. What sort of tools do you use when measuring that, and how do you kind of assess relative success?
So we're going to, we just instituted a new set of dashboards by, and we kind of like take a pyramid approach. At the top is the whole practice. And then we go down and we, and I'll use our Northshire site as an example. And then we look at Northshire as a practice, that's in Manchester. And then we go down to the individual provider. So we look at all those dashboards, and on the dashboard it'll have panel size, it has visits, it has what else does it have, Trey? I'm coming up blank.
It has RVU data.
RVU's data. Yep.
And then we've got separate, not right on the dashboard, but right behind it, patient experience data.
Yes. So, we'll be looking, and we have benchmarks set that all the providers have agreed to. And, while we will be looking at them as we're, and Trey said, we're at the 5%, increase mark. So we're seeing successes. The quarter from July to October, we're looking to get to that 10%. And then in the 24 budget year, we're going to be in that 15%. So those dashboards, and they'll be, I'll say, we'll have some successes. And we'll probably have some people underperforming or practices underperforming. We'll have to take corrective action and find the cause and effect if they're not performing. And hopefully, if one practice is doing better, we can learn from that practice, best practices. So we have a lot of data flying around, but we are using sort of like I like to call the pyramid effect. You either work from your top down or you can go from the bottom up, depending on how you want to look at it.
Thank you. And I was also curious if you don't mind sharing, as you look at, do you have like benchmarks like for visits per day, or is that
Yes.
like, okay.
Absolutely.
Yeah.
Visits per day, visits per week, remember, physicians do take vacations. So, sometimes you see one physician, he's doing well, and then all of a sudden he drops off. Well, you got to look, he's on vacation, he took a day off or whatever, but we have a visit per day target. We have a visit per month target, so we'll be looking at it, and when you start looking at an individual day, that's too micro. You got to look at the long haul. Okay, and then we look at the weekly, we look at the month, and then ultimately, we'll be looking at quarters and then year. And the success will really be, we'll really start getting a feel when we get our first quarter under our belt, and then our second quarter, and we hit that 15% increase over the long haul.
Yep. And how are the benchmarks derived for those targets?
How are they derived? Well, we're using national benchmarks, and we're using Trey, I think three standards.
Well, right. It kind of depends on what measurement you're talking about, because some of the resources are good with certain measurements and not others. And, it's actually a little complex there. You have to make sure you're looking at like institutions. So having an academic center compared to a community hospital is not correct because of residents' involvement and all that. But we use a blended survey for every single one of those and for panel size for the primary care. The goal, I just have to point out, since it's a public forum, the goal is not to see who's performing poorly. The goal is to see where are the opportunities to have everyone performing at a comfortable level that is good for their well-being and improves access. And that's the approach we've taken, and we have much better buy-in than if we, did it in some other way. I know that goes without saying, but I think it's important to point out. And it actually is really good to compare office sites, because if you have 4 primary care office sites that, maybe you've adjusted a little bit for the type of patients they're seeing, but they should be pretty similar. And when they're not, one can learn from the other. We can learn from the other. So that type of learning, and I think that's what Steve's talking about with the pyramid measurements.
Absolutely. And I guess to be clear, like, are you looking for median generally? How do you kind of set your relative performance targets?
Yeah, I can answer that as well. So it depends what you're talking about. If you're talking about RVU, we have less than median because Vermont is a lower utilization state. So we don't want to be Florida. That's overutilization. But we also want to make sure that utilization is at a certain level, because that reflects access and reflects volume. So that's why it's not just one measurement we follow. We follow the panel size. Typically we follow a lot of things, but what's really out there on that dashboard that Steve was talking about is panel size. If we're talking about primary care here, panel size, visits per day, total visit volume per month adjusted for FTE, and then RVU productivity as well as patient experience.
Thank you. Very clear, very obvious how you attend to that. And then I was also curious, you mentioned all the efforts to, review inpatient admissions, make sure they're appropriate, it's the right answer for that case, efforts to shift more care to patients' homes and alternate settings. And just as you work through this, I think, broader transformation process, just curious, where you're kind of finding some pain points and what you think is already kind of paying off in terms of the results.
So Trey, I'll let you take that and then I can follow up.
Sure, that'd be great. Well, first off, just on admissions, we have the physician's decision, which actually does trump all depending on the medical assessment. Then we follow what are called interqual criteria. Most people are probably familiar with that. There are some other benchmarks, but allowing whether or not a patient can be admitted to the hospital on observation or inpatient. And then, we also work with DHMC to make sure we're aligned with metrics throughout the entire Dartmouth health system. But you asked about pain points, and I'm going to say the same pain points that I think you're going to hear from all, the community hospitals here, and that is it's not really admissions, it's discharges. It's so difficult right now getting patients to psychiatric facilities. So they end up, to tell you the truth, they end up often going to a suboptimal environment. And that is really hard on the well-being of the nursing and physician staff because they know they are not doing the patient doing what's really in their best interest. They're doing what, it's not the path of least resistance by any means, but it's the path of best resistance at that, best path for that particular moment in time, because the other options aren't there. And it's the same with the patients going to skilled nursing facilities. I'll say it, I know that you've heard it, it's real. We have patients waiting for so long, they really should not be in the hospital, and it's not good for them, it's not good for staff. That's one of the biggest pain points. We have transportation as well, getting patients to tertiary care centers and to skilled nursing facilities is a real problem.
So another pain point on the administrative side is that, as Trey said, the physician believes the patient needs to be admitted. The patient meets qual care, interqual criteria, interqual criteria. And then a month later, after we bill it, we get a denial. And those denials have increased, which is increasing an administrative burden. And it's a difficult time, and we understand what the insurance companies, what they need to do. But as Trey said, it starts with the physician making the decision on the front line, and then if it's validated, we have some difficult times, and we spend a lot of money and time working. And sometimes we take the physician away from the patients because they got to get on the phone with the insurance companies to justify their decision. And so there's a lot, and we've seen a significant increase in the workload related to retrospective denials. So another pain point.
Thank you very much. And then always interested in the validity of our information. So was curious how well our migration information might tie to what you see in your data. Probably easier to look at it from the in migration than the out. That's a little harder for you. But just do these kind of magnitudes feel reasonable? Are we totally missing the mark on some of these measures, or I don't know how close you had a chance to review?
Yeah, Sarah, I didn't have that much. We haven't reviewed this chart much, but let me just give you a perspective. About 22% of our net patient service revenues comes from the state of New York. That's based upon cash collections, that's internal data. And about almost 9% of our cash collections comes from the state of Massachusetts. And then 2% comes from every place else. And then the remaining are Vermonters. This is based upon the address that the patient gives us when we register them. And the payer mix,